everybody. My name is Sarah Beckham. I am the Associate Director for the UW-Madison Center for South Asia. Welcome. We're very excited that you're here to join us for this wonderful panel. And before we begin, I'd like to just go over the format of this panel. So our speakers will speak for about 20 minutes each. And for those who are in attendance, if you could just, as they're speaking and you have questions that come up, just type your questions into the Q&A because both of the panelists will be able to read that. And then once we reach the Q&A section, then they'll actually have time to have reviewed your questions and can dive right in. So with that, I'd like to start with a couple of announcements. Next week, which is actually in 2 weeks from now, my apologies, Thursday, October 29th, we have a panel on caste, indigeneity, region, and settler colonialism in Modi's India. And this panel comes from one of the accepted panels of the annual conference on South Asia, which unfortunately had to be postponed. And that will be from 3 to 4:30 p.m. Keep a lookout on our website and in our bulletin because that is by RSVP only if you are outside of UW-Madison. And if you are inside of if you are at UW-Madison and receive our weekly announcements, you will receive the Zoom link. So I'd like to begin our introductions. We have Dr. Ann Behrmann and Dr. Vijay Limaye here. So Dr. Ann Behrmann is a Madison pediatrician who worked for more than 3 decades with Group Health Cooperative of South Central Wisconsin. Her interest in international child health began with a month-long rotation in her second year of a UW pediatric residency working on the Atlantic coast of Nicaragua. She has worked over the years on abolition of nuclear weapons, violence prevention, and environmental health issues with Physicians for Social Responsibility Wisconsin and the Wisconsin Environmental Health Network. After a year's sabbatical in North India at the Tibetan Children's Village, she continues to work with the American Academy of Pediatrics section on international child health as a grant advisor, reviewer, and facilitator for the iCatch grants, now currently serving a 3-year term as the AAP iCatch Program Director. 2 of her ongoing international projects with UW's Center for South Asia are funding a school lunch program and advising on health and nutrition at Chingari Rehabilitation Center in Bhopal, India, and creating and implementing a school health program at the Tibetan Children's Home in Dehradun, India. In collaboration with UW School of Medicine and Public Health, pediatric faculty and residents, and 2 other academic pediatric programs, knowledge and experience from the TCH will be used to develop a global school health toolkit online resource for pediatricians and school health providers worldwide. So thank you for joining us, Dr. Behrmann. And Dr. Vijay Limaye is a climate and health scientist at the Natural Resources Defense Council, NRDC, an environmental advocacy nonprofit. As an epidemiologist, he is broadly interested in addressing international environmental health challenges, quantifying, communicating, and reducing the risks associated with climate change with a focus on the public health burdens of air pollution and extreme heat. At NRDC, he leads economic evaluation work to demonstrate the significant health costs of climate change, and he works to defend the science that underpins the Clean Air Act. Prior to joining NRDC, he worked as a U.S. Environmental Protection Agency scientist, focusing on Clean Air Act regulatory implementation, air quality monitoring policy, risk communication, and citizen science. Dr. Limaye, who also speaks Spanish and Hindi, has published several research studies on the health impacts of climate change-triggered air pollution and extreme heat in the US and India. He holds a bachelor's degree from the University of California, Berkeley, and a PhD in environmental epidemiology from the University of Wisconsin-Madison. So we're thrilled to have one of our alum joining us today. So welcome to both of you, and I'll hand it over to you.
Hi, everybody. I'm going to be pretty informal, and I'm going to share my screen and try not to read too much, but can you all see it all right? And should I put it, I'm going to see if I can put it in view form for you, just so you can maybe read it better. So It's true. I'm a pediatrician. I actually retired from group health in 2016, and hopefully it's not too many of you that were my patients. That's always happened to me at the U. But I wanted to kind of talk about how I got involved with the Center for South Asia. In working for group health, which is a wonderful place for me to work, and to let you know that in my last decade or so of work there, it was mostly with kids with disabilities and brought on by what I did in India. But group health had a sabbatical policy. After 10 years, you could take a year off without losing your employment at group health to do something that was related to pediatrics for me. And so I made contact with the Tibetan community here in Madison and was able to spend most of a year with my husband, who worked at the Tibetan Library and Archives, and my son, who was then 7, at the Tibetan Children's Village School in north of Dharamsala, India, north of McLeod-Ganj. From the fall of 1995 through the spring and early summer of 1996. I went back to TCV and worked for near another month 5 years later as a fill-in doc, while my brother, who was a special ed prof at George Mason University, came with his graduate students to teach a 2-week intensive to teachers there about kids with special needs. I then went back to, I didn't go back to India until with the former associate director of the Center for South Asia, Lalita Duparan, and I kind of put our heads together and designed a course, first a spring semester course and then a field course in 2011 and 2012, focused in Bhopal at Sabhavna Clinic. And while I was at Sabhavna Clinic during the first field term in August of 2011, I revisited Chingari Trust. And I'm going to talk about Chingari Trust and the Tibetan Children's Home, different from Tibetan Children's Village, a little later in my talk. So I thought I better figure out where South Asia is. I mostly have worked in India. I have friends in Pakistan and Bangladesh, but I've never been to either of those countries nor to Afghanistan. And as a pediatrician in speaking at scientific meetings, you often have to give a disclaimer. And my disclaimer is I don't consider myself an infectious disease expert nor a global health expert, but I'm just going to tell you what I've learned from reading what Laurie Dupree Brown would call the gray literature, what's really happening in terms of COVID in India, and also in contact with my friends at Chingari Trust and the Tibetan Children's Home. So let's see where the US, this is 2 days ago in the US, and at that time we had 8.75 million cases of what we call now COVID-19, which is really a SARS coronavirus 2, a pandemic disease that came as a novel disease from first diagnosed with people and identified in Wuhan, China, and just the end of December, beginning of January of 2020, well, not 2019, hence the name COVID-19. But in the U.S., we have, we're top of the line for the number of cases of COVID-19 in the world, at, like I said, almost 8 million, and have had about, over 200,000, close to 215,000 deaths from COVID-19. And this is the kind of stuff you'll see. This is from the Centers for Disease Control, the graphics to talk to people about practicing social distancing and wearing a mask. Sadly, I just say as a disclaimer, I don't think the federal government has done a very good job, although this is from the CDC, at having guidelines that everybody feels are safe and what they need to follow. But I wanted to compare our disease numbers in the US with the disease numbers in India. And as you can see, India is pretty close to the same numbers as we have, about 7 million cases, over 7 million cases. The fatal cases are less at about, this was 2 days ago, 110,000, but you need to remember that in India, they have a very different medical system than we have in the US. 70% of people in India still live in rural areas, although the first places that COVID-19 hit were the big cities, which is not surprising, since there's a lot of travel, both within the many states of India, but also internationally into Mumbai and Delhi and Bengaluru and Chennai. So it's not so surprising that those big cities were the ones that were first hit. But cases are lower, and why are they half our cases? Well, there's question about the count. We know that some of the states in India didn't count COVID-19 deaths if they were associated with a death from, say, diabetes or cardiovascular disease, which was considered the primary cause. But certainly the reason they tipped over was probably COVID-19. And that's been corrected now. But also, you know, with 70% of people living in the countryside, deaths are usually reported from hospitals, and many of those people died without reaching the hospital. On the right side, you can see a poster, a COVID-19 poster, not much less graphic and much more written, and I know you can't probably read it, but about to do and don't do, that's been put up all around Bhopal by the people at Its Bhavna Clinic and Chingari Trust to try to do health education of the local populations. So what happened in India? Well, things were pretty slow in India to start out. And I was there until the 9th of February. The pediatric residents in the RN that I was traveling with and working with at Tibetan Children's Home during January and early February were still there until I think about the 12th. And I didn't realize until starting to do research for this that the first case of COVID-19 in India was at the end of January, January 30th, from a student that was studying in Wuhan that returned to India. But things were kind of slow, although the Indian government finally decided it's going to be a problem for us around the middle of March. And suddenly, starting on the 22nd of March, but officially on the 24th of March, with 4 hours notice, Prime Minister Narendra Modi started what was initially to be a 7-day lockdown. Everybody should stay in their houses. The only things that were open were medical facilities and food stores. No buses, no trains, no one should be driving private cars, nor rickshaws, et cetera, et cetera. Everybody needed to stay home. And that was problematic for India because such a huge population of India are still poor and are still day laborers, meaning that they glean money for their families by going out and doing work day to day in the, in construction and in agriculture and other things, and they had to stay home. So those day laborers really had a huge problem. Also, about 140 million workers in India are considered migrant laborers. And this is mostly considering migrant labor to other states in India away from their native villages. And with the lockdown, and for the first time in 167 years, the Indian rail was shut down. These migrant workers had no way to return home. There were no buses, and they often had no jobs. They had no money. The places they lived were sometimes part of factories or building sites, and those were closed down, so they couldn't stay there. So many people took to walking, and sometimes hundreds of miles to reach their home villages. And what's not only problematic for people starving or dying of exhaustion on the way home was also that they often, many of them were infected with COVID and spread that COVID into the rural areas of India. The other big thing about India, India had already had some big shocks to its economic systems. In January through March of 2018, India's GDP growth was about 8.2%, which was slower after they devalued money in 2016 to try to stop corruption, one of Modi's initial forays into trying to change the system. By January to March of this year, it had gone from 8.2% to 3.1%, and now at the end of August was they have been calculated to have lost about 24% of their gross domestic product for the year ending in June of 2020. So minus 24% GDP growth. That's a huge, huge issue, not only for people in the middle class who can work from home, but even more so for poor people. And that's quite like it is here. The Modi government did on March 26th, open up $24 billion in US, or about 170,000 crore in stimulus funds to act as direct cash transfers to the poor people, including these migrant workers. But the problem was that few people were registered to receive federal food in the federal food welfare scheme. So of that 24 billion, not so much of it got to the people it needed to go to. They also made available free cereal and cooking gas for 3 months, and insurance coverage, interestingly enough, for medical personnel. And now for those people that returned home, and it's considered probably close to 100 million migrants that returned to their home villages. There's been a big increase in the use of something called the Mahatma Gandhi National Rural Employment Guarantee Act, which was started in 2005. It wasn't used much. And it's an act that allows people to get 100 days of labor, paid labor, usually doing community projects like improving water sources in villages. And as of, I think, September, they said 30 million people had applied for these jobs in this Mahatma Gandhi National Rural Employment Guarantee Act. And many were people that had university degrees that can't find jobs. So some way to feed their families. Okay, what about healthcare in India? It's problematic. About 30, in the US, about 91% of people have insurance. It's not always great health insurance, but it does cover some of the costs of healthcare. In India, only about 35% of people have insurance. There is a national health plan mission, both an urban and a rural aspect of that, which provides free care through government hospitals. But the problem with government hospitals is that although the consultation fee, if you saw the pediatrician or the obstetrician, is free or I know most recently in Dehradun, it was about 28 cents to register a person to see the doctor. But the cost of medication, the cost of laboratory tests, the cost of testing such as ultrasounds and x-rays are in addition to that. There is, for children, some relief for kids that are hospitalized with disease for the first few days of their hospitalization. But really the brunt of trying to figure out what you have and how do you treat it, the payment for that falls upon the family themselves. Coronavirus testing in India, right now in the US, we test about 100 people per every 1,000 population. In India, it's only about 40 people for every 1,000 people. So not up to the numbers that we need to see happen in that country, which is pretty common in low middle income countries around the world. I just was talking to Sarah and Andrea and Vijay, and what I read most recently was the hospitals had been doing pretty well in India. Most of the COVID cases were being treated in government hospitals and medical schools. But as of this last month, 80% the private hospitals, I think in the larger cities all over the country, were asked to open up 80% of their beds to cover COVID-19 patients. And they're making isolation areas for people to get away from families because of the problem with crowding. And in the unused railway coaches is one of the places, as well as wedding halls, etc. There has been some literature coming out of India that's been really important in looking more at COVID-19. This was a study that was done by the Center for Disease Dynamics, Economics and Policy in New Delhi, and some partners at Johns Hopkins here in Baltimore, looking at transmission dynamics of COVID-19. Because India actually has, in the southern states, particularly Tamil Nadu and Andhra Pradesh, Kerala, some really pretty well-developed public health systems with contact tracing. This was a study that looked at contact tracing, trying to figure out what the transmission rate was for people at different ages. And they were able to show that actually kids, in the US, there was debate about whether children could infect other children. And actually they found out that was true, but mostly they infected children. They didn't infect the older people at other generations. So what's the impact on kids for COVID-19? Well, UNICEF put out at the end of July this press release that said, we presume that an additional 6.7 million children under 5 could suffer wasting this year from COVID-19. Wasting means that you not only are underweight for age, but you're also under height for age, which is really a marker for not acute, but chronic malnutrition. So what about for kids? That's one of the things, I guess if you take away anything from this talk, I want you to think about India's children and what it means for them. Certainly increased malnutrition is going to be a big problem, and they're not really sure yet whether it's going to be 0.5% of the reduction in weight or severe underweight and wasting, or it's going to be as high as 5%. So, but it's going to be somewhere between, 750,000 children to as many as 7 million children in India could be affected. Most kids under 6 years of age who are poor receive their health care as well as child development and growth monitoring from Anganwadi centers, which are health centers in communities that are manned by about 1 million Anganwadi workers, who are people that are kind of like, I guess, nursing assistants who are trained. So they receive they receive not only medical care and immunizations, which is really important, but they also receive, children under 6 years of age receive a hot meal. Pregnant women and women who are lactating also receive free food, hot meal a day, and any children under 6 months of age or babies receive takeaway food. So increased malnutrition is a big issue because the Anganwadi centers closed also around the 22nd of March and have not reopened as yet, just like the schools. Missed childhood immunizations are a huge worry, particularly for tuberculosis, because children who are born in hospitals receive BCG vaccine to prevent non-pulmonary spread of tuberculosis. And that they have already data to say that these infants have not received BCG vaccine, as well as some key vaccines like measles, which is probably one of the most infectious diseases known to man. And a measles epidemic is something that we often see in refugee emergencies. And I think people are very worried about what's going to happen in India. Interrupted education, I'm going to talk a little bit more about it in the schools, but worldwide about 24 million kids are out of schools. The schools closed in India on March 6th and have not reopened. There's some private schools that are beginning to reopen, but mostly they're trying to do school online, which is problematic. So what happens if your kids are out of school and your family is starving? Well, you send your kids to work. Even kids as young as 6 years of age can be rag pickers. The incidence of child trafficking and young girls entered into the sex trade early is another big issue. Teen pregnancy for sure, and forced or early marriage of kids under 18 is another big thing that we're going to see not only in India but elsewhere in the world. And in the US, there's a lot of there's a lot of misinformation on the internet. And so about 400 Indian scientists decided to get together, and they've been doing something called the Hoaxbusters. And they've been putting up posters and mostly things on the internet to tell people that no, actually you aren't protected from COVID-19 by drinking cow urine or smearing cow dung on yourself. But things like maintaining physical distancing and wearing masks is really a good idea. So I'm going to talk to you lastly about 2 schools in India that I'm involved with to kind of give you an idea about what's happened to those places. That's kind of what I know about most. This is Chingari Trust, and this is the school that Lalita Duparan and I know well, and also the students that were part of our summer field terms in 2011 and 2012. It was near Sabhavna Trust clinic that took care of Bhopal gas victims. This is a clinic that takes care of kids with developmental disabilities, and often third generations, their grandparents were the ones that were exposed to the methyl isocyanate from when there was the explosion in India in December about 36 years ago. This school was started by 2 women, one Muslim, one Hindu, who won something called the Goldman Environmental Prize back in the 1990s. And it's a school that they use the prize money to start this school, and it provides free van transport. They pick kids up with a family member and take them to the center. This was before COVID. And at the center, they receive free physical therapy, occupational therapy, speech therapy, and also special education. You can see some of the pictures there. There's a nice little playground in the center. And, when we visited and did some free health physicals there, which is what the center asked us to do. I was there with medical students and nursing students and some pharmacy students. And we only did it on about 3 dozen kids out of the, at that time, 150 or so kids that were registered. We found that a huge number of these kids were not only were underweight and malnourished, and it wasn't just kids with cerebral palsy who have trouble eating. It was also kids who were deaf. There's about 30 kids at that time that had hearing aids, and there's no reason the deaf kids couldn't eat properly unless they didn't have enough to eat, which is, so what we talked a lot to our friends at Chingari Trust, and what we decided to do was to start a school lunch program for these kids who are spending 4 hours a day at school with therapy. There's now 300 kids in 2 sites right across the road from each other that receive therapy, and they come in 2 shifts, and they're fed a wonderful hot school lunch, all vegetarian, pretty much vegan, except for 1 day a week when they get here, big treat. You know, they also do things like take kids on field trips. This is a field trip on the side on the right to the railway station to kind of teach kids activities of daily living, we'd say, for kids with developmental disabilities. And they were really interested in this quick investigation team, which is the police at the railway station in Bhopal, because one of the policemen had a deaf daughter, and he used sign language so he could speak to the kids and so talk to the kids about what to do if you're lost. Okay, so what's happened? Well, Chingari Trust is closed, like all the other schools in India, and you know, incredibly enough, and not surprising, knowing all these colleagues that work at Chingari Trust, both the physicians and the nurses, but also the therapists and the teachers and the staff at Chingari Trust, they have now fed with our school lunch program funds about 200 people for 40 days straight. They provide 800 packets of food staples. That's what you can see in the lower right-hand corner, to families whose children were patients at Chingari Trust. And they've started to do home visits for physical therapy and occupational therapy and speech. And they've done more than 1,900 home visits in the last 4 or 5 months as this got started. They also work with Sabhavna to do health education in the communities around the Union Carbide plant, in the communities that were affected by the gas attacks, and some, I think, COVID-19 testing as well. The other place I worked and was at most recently, these are pictures actually from 2017, but I was there just in 2020 at the Tibetan Children's Home, which is in the Tibetan enclave, Clement Town, outside Dehradun in Uttarakhand. And this was school before. They had a school at TCH for kids under K through 5th grade, as well as a preschool that I don't have pictures of here. About 60 kids, 66 kids stayed, were boarders at the school, so slept there, ate there. They had a cultural program, really wonderful place. Of that 66 kids, 27 were ethnically Tibetan from the Mampa tribes in Arunachal Pradesh. And there was big debate during lockdown about what to do for kids in boarding schools. And finally, the families in Arunachal Pradesh appealed to the chief minister of Arunachal Pradesh, who coordinated with the chief minister of Uttarakhand, and they found funds to pay for 27 of these kids to return by bus and train to their families. TCH paid for food at the time during the travels, and also paid for food during 14 days of quarantine in a local community health center before the kids could reach back to their families. So I also want to say that our work in India has been with 2-day schools, one in Herbertpur, which is also in Uttarakhand, a few hours drive from Dehradun, and Jagriti Vidyala, a small 100-student free school for poor children in Dehradun proper. These schools have been closed since lockdown, and as you might imagine, these are not kids that are going to have access to internet. Their family might have a phone, probably not an iPhone or an Android, but maybe just a flip phone. So it's difficult, and some of the schools have started providing, as TCH did, books for kids to learn, and ways for parents to bring their written work in to be graded, but it's a huge, huge issue and a big uphill battle to get kids back in school after the pandemic. I think that's about all I have to say. I'm going to turn it back over to Vijay.
Great. Thank you, Anne. Those were
You're welcome.
really great information to hear, and I think it'll tie in nicely to some of the content that I'll share. I'll just get my slides going here.
Let me see if I can okay, stop sharing. Right.
Okay, great. Okay, great. So I'm going to follow up on Anne's great presentation by talking a little bit more broadly about some of the other risks to public health in South Asia right now, and the ways in which the climate crisis really intersects with long-standing chronic problems of air pollution. So as Sarah mentioned at the top, I'm Vijay Limaye. I'm a UW-Madison alum. Very grateful to be back here with Center for South Asia. And I had wonderful interactions with the center as a student, and I'm really thrilled to be with you all today. So, one of the main points I want to make in today's talk is that climate change, we might have in the past thought of it as some distant threat far into the future that was sort of incrementally, slowly growing in urgency. And I think, this year, even the past couple of weeks here in the United States have demonstrated that this threat is here and now, and it's affecting our health, it's affecting our economy, it's affecting nearly every aspect of life. And so really it's, I think, time to think about this problem as a people problem, as a health problem, and less about, the engineering and technical challenges that we face in encountering emissions. I think that a people-focused framing on the problem can help to hopefully motivate action to address it by reducing carbon pollution and also better preparing communities across South Asia and other parts of the world for the climate harms that we know are on the way. This figure is kind of a landmark document in the climate change and health space. It was first introduced, more than 20 years ago by my PhD advisor, who's a professor here at UW-Madison, Jonathan Patz, who leads the Global Health Institute and also works in the Nelson Institute for Environmental Studies and the Population Health Sciences Department. What this figure shows is really how the climate crisis is really a human health issue. And that's because climate change is basically driving a number of key changes in the ways that our Earth system operates. Of course, we all think about temperature rise as we think about the increasing concentration of greenhouse gas pollution in the atmosphere. But climate change is also linked to other environmental changes that are especially relevant to communities across South Asia, especially sea level rise and the changing hydrologic patterns. So increasing frequency of both drought and extreme precipitation. Sometimes those effects converge. We, for example, see that warmer ocean water can drive stronger coastal storms, and certainly that's of great relevance to the millions of people living in coastal areas in South Asia. So each of those environmental changes is linked to a whole host of different adverse health responses in human populations. In today's talk, I'm going to focus on extreme heat and air pollution, but I will note that there's a whole sort of field of study that's relatively young still, but growing in terms of its specificity to specific health problems linked to the climate crisis. And certainly, South Asia is vulnerable to a great many of these harms when we think about the health risks of some of the warmest temperatures ever recorded on the planet being recorded in South Asia, relationships between climate change and air pollution, which I'll describe in a lot more detail, but also the other side of the burden in terms of infectious disease distribution, things like malaria and cholera that are affected by climate change. So this is a whole area of study. I'm going to zoom in on a couple topics, but maybe we can get to some of the other ones in the Q&A. I also want to frame this issue as a health equity problem and an ethical crisis. This is another key figure published by Jonathan Patz, really demonstrating the sort of mismatch between those countries most responsible historically for carbon emissions that are changing our climate at an unprecedented pace. Each country here on this map is represented in terms of its historical contribution to global carbon emissions. So you can see that the United States is amongst the top offenders here, and the sort of size of each country is scaled to the billions of tons of carbon that it's estimated to have emitted between 1950 and the year 2000. So we can contrast this map, which is called a cartogram, with another map, which tries to crudely estimate climate impacts in different regions of the world. So here again, each country is scaled in terms of its relative impacts. The changes here are health impacts, so changes in diarrheal disease, the incidence of malaria, which is a mosquito-borne disease that's affected by climate, as well as the incidence of inland and coastal flooding and malnutrition that's expected between the year 2000 and 2030. So the take home from these two maps is that those that are the most vulnerable to climate change related health impacts are the least responsible for carbon emissions. And so really this is a health equity issue when we think about global public health and our response to this problem that's affecting everyone on the planet, but in different ways. So I'm going to zoom in to talk about air pollution a little bit because it's often an issue that comes to mind across South Asia. And I want to just start by providing a little bit of context for the types of air pollution levels that we see in places like India and Pakistan. So here's just a sample of some of the cities in the US that historically have had some of the worst pollution. A lot of them are in California, a couple on the East Coast. You can see that the PM 2.5 levels, one type of pollution level, basically range between about 20 and 40 in the United States. We can contrast those concentrations with levels in places like India and China, which often experience air pollution levels in the most polluted cities that are about an order of magnitude higher, right? So we're seeing that India has, more than half of the top 20 most polluted cities in the world. And certainly China has made a lot of progress on this issue in the past 5 to 10 years, but India still struggles, especially in the wintertime, with some really high pollution levels. It continues to make headlines. Often, in the past, I think people sort of binned India and China in the same place in terms of the air pollution struggles, but more and more we're understanding that the chronic air pollution exposures in India are affecting human health in a number of ways, shortening lifespan, reducing the lung development in children, and basically burdening the economy with this glut of air pollution related disease and early death. To counter that situation, I think, the lockdowns that Anne mentioned that happened earlier this year really delivered some short-term dramatic reductions in air pollution. A lot of these made headlines. That figure on the left is pulled from The Guardian. The picture on the right is one that my cousin Supriya in Pune sent me of a clear night in the city in late March. For many people, these conditions that were experienced under the lockdown were some of the cleanest air that people have ever been exposed to in the country. And certainly there was a lot of hardship and suffering that people endured as a result of that lockdown. But one side effect was really showing that there is a strong link between human activity and clean air. This is a problem that we know how to address. Obviously, we would hope to address it in a more equitable, sustainable way. But I think this really did open up some eyes in terms of the rapid response of our environmental systems to changes in human activity and the ways in which we might sort of learn some lessons from those hard couple of weeks in March, April, and May. So when we think about air pollution, I do want to demonstrate just sort of that a lot of the air pollution that we see is basically a visible symptom of the climate crisis. So when we talk about the top offender in terms of air pollution and human health, we talk about particulate matter, which is basically the only air pollutant that's defined by its size rather than its chemical composition. This is basically an umbrella term to describe a number of basically toxic components, including acids, organic chemicals, tiny metals, soil and dust particles, all of which come from both natural and human sources, although humans have a dominant influence on PM 2.5 levels. These are basically really important from a size perspective because they're microscopic. They're naked we can't see them with our own eyes, but they're very tiny and actually able to penetrate very deeply into our respiratory tract. So you can see here, there's a couple of parts of the lung and the bronchioles that are highlighted here, basically demonstrating deposition of these really tiny particles into the deepest parts of our lung, where they're actually able to enter our bloodstream. And it's because of that they're actually able to inflict a whole host of damage to organ systems in the body, everything from heart disease and lung cancer to heightened risk of stroke and dementia in human populations. We learn more and more practically every day about the harmful health effects of PM pollution. And it's also very key to understand sort of the implications of the current pandemic situation in places like South Asia that are coping with high pollution levels. Some of you might have seen research that emerged earlier this year about the COVID-19 pandemic and its relationship to air pollution. Basically, there's been a bunch of research out of China, Europe, and the United States pointing to increased severity of COVID-19 cases in places with higher air pollution levels. As a scientist, that's an intuitive finding for me because I know that there's a lot of overlap between the types of health problems that are triggered by air pollution, like heart and lung disease, and those pre-existing conditions that put people at heightened risk of severe complications or even death from the coronavirus. So we've been trying to make the link through our advocacy work that air pollution is a problem from a health perspective, and it's going to remain one. And that just as we're taking, these immediate measures to reduce risk and exposure and spread of the coronavirus, we also need to think about health equity and ways in which we can improve the air pollution situation, improve people's diets to ultimately, help people cope with a viral pandemic that we know is going to be with us for months, if not years to come. We really need to put everything on the table when it comes to building our global health response to this problem. In terms of action on the air pollution problem, I do want to offer some hope and positive examples through this talk today. Some of the work that we've been up to at the Natural Resources Defense Council is in the western state of Gujarat, in the city of Ahmedabad. This is a city that has taken the threats of climate change when it comes to extreme heat very seriously. And it's also lately been working to heighten public appreciation for the health harms of air pollution. So here the images show some examples of the communication of what's called the Air Quality Index, basically a way of translating current air quality conditions into a color-coded system to give people out in the public a better understanding that air pollution actually affects them and their children, and that there are actions that they should take depending on how severe the air pollution problem is. We've done quite a bit of work to get this type of information translated into local languages. We just launched a similar program today, actually in Pune, trying to disseminate health risk communications in as many ways as possible. So to do that, we're taking advantage of a similar sort of model as employed in the United States. Basically, this color-coded system translates air quality information, translates numbers into plain English or plain Marathi or wherever we are in the local language to try to explain who's particularly vulnerable to specific levels of air pollution and what actions people can take in order to respond to these problems. We have seen over and over through public polling in India that air pollution is still not widely appreciated as a health problem. It's not appreciated that air pollution actually affects test scores in schools, for example. And so there's quite a bit of work to be done to communicate that this isn't just an issue of aesthetics or sort of a confined sector of the economy, that this is really a problem that's affecting everybody and burdening the entire economy. Some of you may wonder what the regulatory structure looks like in India. I did want to pull up what the country's national air quality standards look like. There are limits on the books in terms of how much air pollution is allowable in air in India, at least. But a big problem historically has been putting some teeth behind these standards. So in contrast to the United States and the Clean Air Act, for example, where we typically sue polluters who exceed permitting limits, and we often place localities under sort of additional pollution control requirements if they're exceeding these limits. In India, the regulatory scheme basically has not enabled enough enforcement to enable long-term sort of sustainable reductions in air pollution, although it's something that there seems to be increasing momentum on based on the country's recent launch about 2 years ago of a national clean air plan. So more to come on the air pollution problem, but I also want to talk about one other threat to health that's related to climate change, and that's from extreme heat. We know, and this map as an example, that regions and cities across the world are experiencing some of the warmest temperatures they've ever experienced, and that we need to, at the same time, that we're cutting carbon pollution, also prepare communities for the climate change that's sort of already baked into the system. And that's where this term climate adaptation really comes into play. It's all about improving community preparedness, anticipating health risks before they happen, and working to equip communities with the tools that they need to protect themselves. We've been working in the same city in Ahmedabad for about a decade to improve extreme heat resilience in the city. Ever since 2010, when there was a heat wave that basically killed about 1,300 people in the span of just a couple of weeks beyond the numbers, the typical death rates from heat. There's been a lot of interest in the city in taking a whole new approach to this problem and basically putting together what's called a heat action plan, a multi-pronged strategy of basically taking all of the municipal government's actions into consideration when we're thinking about how to respond to extreme heat. So this plan is based on 4 key pillars. I won't focus a whole lot on them, just to say that it's a collaborative project between many levels of the Indian government, including the India Meteorological Department, which develops forecasts for extreme heat, public health professionals in the city who are increasingly communicating about climate change and extreme heat as health risks, and efforts to basically change the physical look and infrastructure of the city in order to reduce the urban heat island effect. So the city has basically developed like the air pollution problem, as a simple alert system to basically provide advisories and alerts for people based on the forecast temperature for that day. It's basically a shorthand way of demonstrating what the risks to human health are and shaping the city's responses based on the severity of the forecasted temperatures. We've seen a lot of interest in community partner engagement on extreme heat. So on the left, you can see an example of a local event to draw attention to the importance of heat as an exposure that can actually kill. It's not just an inconvenience, but something that's important to take into consideration in terms of protecting public health. On the lower right, there's an example of a cool roof project, basically an attempt to improve the amount of incoming solar radiation that's reflected back out rather than absorbed into the urban environment in order to slightly dampen the effect of these increasing temperatures at the urban scale. You might ask what effect these programs are having on human health. And I'm happy to report that Ahmedabad's Heat Action Plan is one of the very few global climate adaptation actions that have actually been evaluated from an epidemiology perspective. Based on peer-reviewed research published about 2 years ago, the plan itself has avoided about 1,100 excess heat-related deaths each year since its implementation. It's unclear which of the 4 strategies are, the most protective in terms of that big number, but it's encouraging to know that the number of heat-related deaths is dropping in the city since the implementation of this plan. In order to sort of broaden the application of this work, we think it's probably necessary, as Anne mentioned, to integrate economic discussions into this element of the problem. There's increasingly attention on climate change as a problem that will dampen India's GDP. This is a headline from earlier this year. I want to point you all to a commentary that I published along with some colleagues here at UW-Madison earlier this year in JAMA, the Journal of the American Medical Association, describing how basically efforts to reduce climate change pollution can ultimately benefit the economy. And we looked at a number of different sectors, including energy and electricity generation, our food and agriculture systems, and transportation. So increasingly, we're thinking about the climate crisis and health problems in terms of health costs. And that's because there's ways to connect these health problems to real dollar figures or financial resources that are being expended right now to deal with extreme heat, to deal with air pollution, to deal with unprecedented flooding from monsoons in new ways. We think that talking about the health costs can really demonstrate the costs of continuing inaction on the climate crisis and hopefully motivate action to reduce those costs and avoid them being burdening communities in the first place. To that end, there's also a lot of interest in talking about the multiple benefits or kind of win-wins of climate action. So this figure demonstrates what's called a Cobenefit Framework of basically trying to demonstrate that because climate change is a problem that affects nearly every sector in society, actions to respond to the problem can reap other beneficial side effects, whether it's improving physical health by reducing our reliance on automobiles, or reducing air pollution by employing greener energy sources like solar and wind. There's, of course, economic savings to be achieved in terms of reduced healthcare spending and increased worker productivity. and ways to reduce health equity, because the climate crisis is burdening our most vulnerable neighbors right now. When we think about meat-intensive diets in the West, there's also ways to make the climate case for the types of diets that are more widely adopted already by people across South Asia that are less meat-heavy and more reliant on plant protein. So we're doing work right now in Ahmedabad to talk about some of these co-benefits, these win-wins of climate action when it comes to air pollution and extreme heat. We're working with experts in public health, energy modeling, air pollution, and climate to basically connect the dots and talk about the multiple benefits for air quality and public health that can be achieved by expanding local use of solar energy, and also expanding the Cool Roof project, and also expanding basically urban greening, the number of trees, green lungs in India's cities that can help to reduce the urban heat island effect and also dampen air pollution dispersion. So in terms of where we're headed, we've got a number of policy recommendations on the table. Of course, we need to reduce the carbon emissions that drive climate change, which will ultimately protect human health in the long run. But we also need to make more ambitious, aggressive adaptation investments to protect people right now for harms that are baked in. In India and across South Asia, we need to improve our surveillance and tracking, especially when it comes to public health. Right now, it's very hard for researchers and policymakers to understand the true breadth of the problem due to limitations in understanding, especially patterns of human illness and disease. Ultimately, that data can help to inform better cost estimates of this problem and the benefits of action. So I want to just wrap up with two hopefully hopeful slides. One is a picture of the US. This is New York City, where my group is based, in 1966. And for many people, I think this is a pretty grim image, but one that might be unrecognizable if you weren't alive at that time. We've made huge strides in this country since 1966 in cleaning up air pollution. And the benefits of cleaner air in this country are tremendous. The Environmental Protection Agency in the US estimates that clean air yields health benefits that are about $2 trillion if you attach dollar figures. So those exceed the compliance costs of basically cutting air pollution by a factor of more than 30 to 1. So certainly there's an economic case to make about the benefits of clean air. And so we've made a lot of progress here, and I think we can take a lesson from the application of scientific information and legal tools to make these cuts visible in other parts of the world. Ultimately, it's clear that action on the climate crisis will benefit us in a number of ways. It will save human lives. It will reduce billions of dollars or rupees in healthcare spending, and that those benefits can be achieved in the near term. They're not something that we have to wait decades to realize. So I think we've got a little time left for Q&A. I'll just leave my contact info up here on the last slide, and happy to help tackle any questions along with Anne. Thank you.